type of deficiency is there. Anemia is basically defined when you have a low hemoglobin level. Usually the level of hemoglobin is around 12 to 18 gram per deciliter. So if there is any condition when you have a low hemoglobin, then it is considered as anemia. Another definition of anemia is that the patient may have also the low RBC count as well. Normal count is 5 to 6 million. So if the count is low, it is also considered in the case of anemia. Also, sometimes the levels are normal, like hemoglobin is fine, RBC is fine, but the oxygen binding capacity of hemoglobin is disturbed. Okay, it is because of the abnormal hemoglobin. जी जी हाँ अभी मैंने कॉल की तो उन्होंने कहा आपकी स्क्रीन आ रही है हाँ मैंने उनसे यही कहा कि मैं शेयर हो कर हाँ आपकी स्क्रीन नजर आ रही है आप शुरू कर सकते हैं स्टार्टेड ओके ओके Okay, sorry for the disturbance. Okay, so we can have things like I was telling you about the definition, the low hemoglobin or the low count or the binding capacity. Binding capacity can be disturbed if you have an abnormal hemoglobin, and that is any abnormality in the hemoglobin, like methemoglobin or any condition where you have low binding capacity. Causes which is basically related with the treatment. The causes of anemia includes the iron deficiency, very common, also very common in our setup. Vitamin B12 deficiency, because B12 is also required for maturation of the RBCs, and the folic acid. So there could be insufficient supply or dietary deficiency of iron, vitamin B12, or folic acid. They are the most common causes of this anemia. Another cause could be if a patient is taking any anti-cancer medicine or like cytotoxic drugs. They also, because these drugs are very potent and they causes the suppression of the bone marrow, so they may also causes the anemia. But the cause in that case is this, the suppression of the bone marrow, so you have to treat accordingly. Aplastic anemia is another condition when any abnormality when the bone marrow is not producing these cells. Sometimes renal disorders, they are also involved because from the kidney a hormone is released or a chemical mediator is released. This is known as erythropoietin, and this deficiency can also causes the anemia. Also, some sort of hemolytic disorder, when you have an increased hemolysis, it can also destruct or decrease the level of the hemoglobin, or it may cause anemia. So we will discuss these one by one. Today's topic is more related with this deficiency of iron, vitamin B12, folic acid, and somehow we will discuss how this bone marrow suppression can be treated, or what sort of stimulator we give to enhance the production of this from the bone marrow. Okay, so you also should know what types of anemia. This has been already. The picture of red blood cells also gives you an idea what is the cause. Like microcytic hypochromic anemia is a typical picture of iron deficiency anemia. So you treat with the iron supplement. Megaloblastic anemia, when you have a large RBC, and that is mostly with the B12 or folic acid deficiency. Pernicious anemia is also part of megaloblastic anemia because this is because of the deficiency of the intrinsic factor. So types is also important. The picture tells you what treatment you should decide it. We start, what is the pharmacological treatment of the anemia? The simple is that the deficiency should be compromised, or they should be replaced. Whatever the missing substances are there, they should be replaced or they should be fulfilled. Like iron deficiency, you have to give iron, vitamin B12, or folic acid. The another way of treating anemia is to stimulate the bone marrow. When the problem is with the progenitor cells, or when the progenitor cells of the blood cells that is present in the bone marrow, if they are disturbed for any reason, like I told you, one of the reason is uh, the anti-cancer drugs. So any condition which causing suppression of the bone marrow, the treatment is different, and we give this stimulating a growth factor. So they are known as hemopoietic growth factors. Okay, the examples are erythropoietin. This we will discuss in detail. What sort of deficiency is there? Although we are focusing on anemia, but in the part of lecture also includes the white blood cells stimulator as well. Okay, so this is the summary, the drug that we will discuss today. So we start with the iron. What is the normal requirement of the iron in the body? Daily requirement is around 10 to 15 milligram. Iron is more required in children because of this growing age. You need more, the children need more iron. Usually the hemoglobin is also high in the children. Also in the pregnant women because of carrying the pregnancy, the newborn. So you need more iron in these conditions. Important thing about iron is that how it is absorbed into the body. This is important because when you are giving medication, you should know what is the physiological mechanism of absorption of this iron. For example, the dietary iron is in the ferrous form, Fe+2 form, and then it is converted in the intestinal cells to the ferric form. And this ferric form is then transported via transferrin and ferritin. Important thing is that when you are providing iron, so if you are giving it orally, it should be in the ferrous form, while if you are giving it parenterally, it should be in the ferric form. Okay, why I've discussed? Because the oral iron is always in the ferrous form, because in the GIT, this oral form is converted into ferric form. Otherwise, in the parenteral form, if you give ferrous form, this will not be, this will not favor the condition, or this will not be working. So in the parenteral form, it should be in ferric form. Okay. Iron, if it is excess in the body, it may deposit in GI epithelial cells, hepatocyte, macrophages, and skin heart. So excess iron is also a problem. So usually, in our sort of setup, people or the physicians who are not who do not follow the SOPs, they start giving iron. Any sort of anemia without knowing the cause, they start giving iron because they consider that anemia could be due to iron deficiency. Do not investigate, and then they supply this iron. So sometimes iron overload is also there, and this may cause the damage to the normal body cells like epithelial cells, skin, heart. So this is known as toxicity of the iron. Okay, so what I describe here is that, what I describe here is that when you are giving iron in ferrous form, oral should be given in ferrous, and the parenteral should be in the ferric form. So this is all here. When you are giving iron, the forms that we usually get is ferrous sulfate, ferrous gluconate, and ferrous fumarate. This could be they are conjugated because of to help the absorption. This conjugation is done so have a better bioavailability. So the iron is conjugated with sulfate, gluconate, or fumarate, so that it has a good absorption from the GIT. When you are giving parenteral form, the iron could be iron dextran, and this is basically the ferric form, ferric oxyhydroxide dextran. And you can also give iron sucrose. Both of these form is basically in the ferric form. Again, the simple names are ferrous sulfate, ferrous gluconate, ferrous fumarate, whereas parenteral form could be iron dextran or iron sucrose. Okay. Again, I've already told you that if you take iron in a larger amount, it can disturb the GI disturbance, nausea, epigastric discomfort, abdominal cramps, constipation, diarrhea. These are the common side effects when you are taking the iron. Toxicity, I just described you that toxicity could be in a case when you are giving iron too much to the patient, or it could be acute iron intoxication, like accidentally a child taken, or you're repeatedly giving iron. And there are some condition where there is also chronic iron over, like hemochromatosis is one of the condition when you are giving a frequent transfusion. So the frequent transfusion, like in the hemolytic anemia, this can also cause the iron overload. So accidental or chronic overload, the treatment, why I'm discussing, because there's a treatment for this iron toxicity or iron overload. Deferoxamine is an iron chelator, and this is parenteral iron chelator which chelate this excess iron. Deferoxamine and deferoxyrox. This is the oral, one is the oral form, the other is the parenteral form. So iron overload can be reduced while giving the this chelatus. Okay, so important thing is that iron could also be overloaded, and you can also handle with this antidotes. Okay, the first part we discuss is the iron, in which we discuss that it has an oral form, it has a parenteral form, oral has ferrous form, and parenteral has the ferric form. Side effects, and then we also discuss that if it is overloaded, you can treat it with the chelatus, iron chelatus, that is deferoxamine and deferoxyrox. One is parenteral, one is the oral form. Okay, the next thing is the deficiency of vitamin B12 or intrinsic factor of folate. These three things are interlinked together, or they have a close association. So I discuss in one go. So any of these deficiencies like vitamin B12 or the intrinsic factor of folic acid, they result in a type of anemia which is known as megaloblastic anemia, immature red blood cells. So these the deficiency of any of them result in this megaloblastic anemia. So this is, I discussed that vitamin B12 is chemically known as cobalamin, and it is absorbed in the GIT with the presence of intrinsic factor. So intrinsic factor produced by the gastric parietal side, this is required. If intrinsic factor, which is a protein produced by the parietal cells of the stomach, if there is deficiency, genetic disorder, or any condition like some sort of gastrectomy or the surgery of the stomach, when we remove part of the stomach, so this, in that condition, when the stomach is removed, so there will be no parietal cells, and there will be no intrinsic factor, or any other disease in which parietal cells are not working, so you have a deficiency of intrinsic factor. So even if you have vitamin B12 in your diet, or you are giving it parenterally, there is no use, because this is not going to be absorbed into the bloodstream. So intrinsic factor B12 is there, and then the folic acid also is required. Folic acid and B12 they work together, and they causes the maturation of the DNA. So folic acid deficiency also results into the megaloblastic anemia. How do you correct this deficiency? Simply B12 is supplied, or it is, the drug form is known as Cyanocobalamin, okay, and hydroxycobalamin. They are the usually parenteral form. Oral form is also there. Okay, this is very common, Cyanocobalamin or hydroxycobalamin, and the injection is around in 100 to 1000 microgram, and this is given usually IM. So B12 deficiency, you diagnose from the picture of the red blood cells, megaloblastic cells, and then you treat it accordingly with a B12 supplement. This is also present in oral form, but parenteral form is more better, and it has a good results. If the problem is basically pernicious anemia or the intrinsic factor deficiency, then you have to give the lifelong intrinsic factor in that case. So this is another condition when the patient is having deficiency or of the intrinsic factor. Otherwise, if the deficiency is simply B12, we can give it like a cyanocobalamin, hydroxycobalamin. Then folic acid is usually given orally. This is a tablet. This is present in the tablet form, and the folic is very commonly used in the pregnancy as well. Overdose do not cause any toxicity. So toxicity of folic acid is not the problem. Even if you have take a high dose, there is no toxicity. Alcoholism and cytotoxic drug like methotrexate causes it, because methotrexate is a folate inhibitor, so it may also causes this folic acid deficiency. Folic acid is usually given in the folic acid form simply, and it is also given in the folinic acid. This is a reduced form, and this is more readily absorbed into the GIT. So leucovorin calcium is the name of this folinic acid, and which is nowadays used, and it absorbs quickly than this folic acid form. Okay, so folic acid can be provided in case of the folic acid deficiency. Okay, so the first part is simply the supplement of whatever the deficiency is there. Okay, if the deficiency is iron, you give it orally or parenterally. If the deficiency is the B12 intrinsic factor folic acid, you treat it accordingly. B12 is formed the folic acid in the leucovorin form. The second part of the talk is about the growth factors. Okay, so if the deficiency is not because of iron or any dietary deficiency, rather than it is because of the bone marrow suppression, so then we have a different treatment, and in that case we give the Hemopoietic growth factors. Okay, they basically stimulate the bone marrow cells, and then they produce the cells like RBCs or WBCs. So what is Hemopoietic growth factors? They are usually a cytokines. Physiologically, they are the cytokines, and they are the glycoproteins. Okay, so they are glycoprotein in nature, and that is synthesized by the bone marrow cells. So normally these cytokines or glycoprotein are synthesized by bone marrow cells to stimulate the process, the hemopoietic cells, and this is how there is proliferation of these cells of the bone marrow. The growth factor nowadays are synthesized by recombinant DNA technology. We have the human derived growth factors, and they are more common in the practice. What are different hemopoietic growth factors we have? For example, if you want to stimulate the erythropoiesis or the red blood cells, then we have the erythropoiesis stimulating agents like erythropoietin. If we want to stimulate platelet, we have a platelet activating factors. One of the example is oprelvelkin or interleukin 11. If the problem is with the white blood cells, then we have the myeloid growth factors that basically increase the production of leukocytes. Like we have example filgrastim and sargramostin. I will discuss one by one. Okay, first thing is erythropoietin. What is erythropoietin? Erythropoietin is basically a hormone or a chemical that is synthesized from the peritubular cells of the kidney. So kidney is basically the area from where this erythropoietin is released, and this erythropoietin basically causes the production of the red blood cells, and they are released from the bone marrow. So any condition which basically disturbs the kidney function usually results in the anemia due to erythropoietin deficiency. People with the chronic renal failure, CRF, they come across with this deficiency commonly, and they are supplied with this erythropoietin. So routinely use anemia for renal failure. There are two forms of this erythropoietin, epoietin alpha and darbepoietin alpha. Remember the two names, epoietin alpha and darbepoietin alpha, and they are the glycosylated form of the erythropoietin. So if the problem is with the erythropoietin deficiency, people with disturbed renal function, then we provide this erythropoietin. What thing you have to keep in mind while providing this erythropoietin or epoietin, that if you could provide it in the higher amount or high doses, the complication could be hypertension and thrombosis, because they produces the red blood cells, and they may causes the thickening of the blood, and that is thrombosis could occur because the red blood cells are producing very quickly. So what we keep in monitoring is that the patients who are given with this erythropoietin, their HP should not be raised more than 12 gram per deciliter. So we monitor the labs, and then we see that if the level is below 12, then we keep providing this erythropoietin. Otherwise, in the case of high hemoglobin level, we stop giving this erythropoietin. So epoietin alpha and diabepoietin alpha, remember the two names for the erythropoiesis or for the red blood cell production from the bone marrow cells. Then in the case of platelets, if you have a low platelets, then you have a thrombopoietin. So thrombopoietin basically is protein, or it's a glycoprotein that basically stimulate the megakaryocytes, which are the progenitor of the platelets. And so in case of thrombocytopenia, cancer chemotherapy causes suppression of the all cells like red blood cells, platelets, as well as white blood cells especially. So in case of any condition where there is a low platelet count, we give this thrombopoietin. Thrombopoietin could be in three forms. Oprelvecin, this is interleukin 11. Chemically, interleukin is a cytokine. I already told you that these poietins are, they are stimulating factors are cytokine in nature. So oprelvecin and romiplastim, this is given subcutaneous. Eltram, Bopag, this is the oral form. So three formulations are there which can be used to enhance the level of the platelets or the count of the platelets. Okay. If the problem is with the white blood cells, or we have problem with the leukocytes, then we give this the granulocyte stimulating factors. The GCSF stand for granulocyte colony stimulating factors. Okay, so this GCSF could be there, and they stimulate basically the proliferation and maturation of the granulocyte. They basically stimulate the neutrophils mainly. Okay, filgrastim is a very important compound. It's a very important chemical that is used to increase the number of leukocytes, because leukopenia is very common in the cancer patients, and you require to increase the level of leukocytes in case of cancer chemotherapy. Similarly, sargromestin is another stimulating factor, and this stimulates the granulocyte as well as monocyte macrophage system as well. So it stimulates the progenitor of the granulocytes and monocytes as well. Sorry. So filgrastim and sargramostim, they are the two chemical I discussed. One is purely for neutrophil, filgrastim, and sargramostim is basically for macrophages as well as for the monocytes. Okay, both clinical use, I told you that both are used after cancer chemotherapy, because the patient with the cancer chemotherapy, they face this problem, and they have the deficiency of these white blood cells. Pegylated form, peg-filgrastim, is another new form of filgrastim, where we combine it with a covalent conjugation with of the filgrastim. It's a modification, and this drug or this form of the filgrastim has a long half-life. So nowadays the peg-filgrastim is commonly used, which has a very long half-life. So two drugs, filgrastim, sargramostim. I thought this is all about the different drugs used for anemia and other condition. This is all the summary, whatever we discuss. Okay, just in one go, you can remember that if the cause of the anemia or is iron, then you can give oral iron, ferrous sulfate, ferrous gluconate, ferrous fumarate. If you want to give it in parenteral form, you have iron dextrane, sodium ferric gluconate complex, iron sucrose. If there is an overdose of iron, if you have to give an overdose or any condition when there is overdose, you can chelate this iron with the deferoxamine. This is the IV form, and deferoxyrox is the oral form in case of the iron intoxication. B12 deficiency can be easily managed by injectable form cyanocobalamin or hydroxycobalamin if there is a deficiency of B12. Folic acid is simply given in the form of folic acid, and another form which is a reduced form is known as folinic acid. Folinic acid is leucovorin calcium in the nature. If the problem is with the bone marrow or suppression of the bone marrow, then you have the hemopoietic factors. And in the hemopoietic factors, if the problem is with the RBC, it is known as the growth factor is known as erythropoietin. That is that stimulate the RBC, and this is related with the kidney cells. Filgrastim is used for WBC and especially for the neutrophils. Sarcomostim is for the WBC, but this is more related with the monocyte in macrophage system. Platelet activator could be oprelvecin, romipastim, and iltomapag. Okay, so this is basically for the platelets. This is the summary of what drugs we discuss in the case of the iron or in the case of anemia, which could be of different cause. So this I summarized, and this is the last slide. Now the session is open for the questions. If you have any question, you can communicate or you can ask. Hello. Yes, I can see the question. Okay. The question is that the thrombopoietin can also be given in dengue. Yes, dengue is one of the conditions when you have a low platelet count, but usually dengue is an acute condition, so we manage it with providing with the megakaryocyte directly. So this could be used, but the management usually is basically of fresh the platelets directly or the megakaryocyte, which is a precursor of the thrombocytes. Okay. So isn't Thrombopoietin not usually given as it has high rates of mortality? No, that's not the reason that Thrombopoietin. We use both of the form, the epoietin alpha as well as Thrombopoietin. There is no condition with the mortality. Okay, the question is, can iron supplementation lead to hemochromatosis? Yes, I told you that chronic overload of this iron may cause hemochromatosis. Hemochromatosis is basically the accumulation of the iron into the in GI epithelial or liver or other things. So very chronic use can cause, but usually this is a complication of the people who are on thalassemia, and they basically have a repeated transfusion. So repeated transfusion could be a cause of hemochromatosis. Otherwise, chronic use of the iron usually do not. But iron intoxication could be seen in this people. Okay, I don't see not any more questions except 4 or 5 questions. Okay, the lecture is simple. Okay, there are not too much drugs in it. Usually, they are commonly the some iron supplements and the growth factors. Okay, okay. Second, vitamin B12 supplementation treat the neurologic problem. Yes, the neurologic problem are basically of the B12 deficiency. Yes, usually the nerves they need B12 for their myelination. So B12 deficiency usually present with the anemia as well as they present with the neurological symptoms. So this is very common. The B12 deficiency is usually treated with this injectable because of this nerve problem. This is very common in our setup. The drugs like methicobal, they are very commonly used. We have the injections or that is given. And this is B12 deficiency or nerve problem is also one of the problem of diabetes patient. So diabetes, they also have the neuropathy, and in that case, we also provide this B12. This is very right that neurologic problems can be treated with this B12 deficiency. Okay, so I wait for 2-3 minutes if there is be any other question. Otherwise, I'll close this session.